another Share for Sodium video. Today I'd like to talk about the physician shortage, which, as you all know, is absolutely something that totally exists, and addressing it by opening more medical schools and expanding residency positions and training more doctors so that we can get more boots on the ground. I mean, this is undoubtedly an urgent priority that needs to be at the very top of our policy agenda, right? I mean, you hear about it all the time. So what part of this could possibly be in dispute? But I hope if you've landed here, you're going to give me at least a few minutes of your time to explore this and maybe think a little more critically about some of the stuff that you're told. And by the end, maybe you'll even have a different opinion. Today, I want you to tell me again about the physician shortage. But I'm going to start with what you already know. And that is that we are facing a looming crisis in this country because we're not going to have enough doctors. You don't believe me? Well, ask the Association of American Medical Colleges. Every few years, they analyze this issue. Right here's their most recent report from March of 2024. As usual, I'll link to it in the notes below, along with all the other articles that I reference. But, this one's not a feel-good read. According to the AAMC's models, the demand for physicians is going to continue to grow more rapidly than supply. And by 2036, we may be looking at a shortfall of up to 86,000 doctors. How bad is that going to be? Well, right now, we're only short around 40 or 50,000 doctors, and we hear about the consequences of the physician shortage all the time. Allow me to offer you just a brief tasting menu of headlines and news stories on this topic, which give you a sense of the burden and diversity of problems that we already have due to the physician shortage. Here's a story from NBC Nightly News. The segment is called Primary Care Doctor Shortage Worsening Across the U.S., and it explains how the supply of primary care physicians is just not growing fast enough to keep up with an aging population. In the story, NBC interviews Dr. Terry Vester, who's a family physician in a small town in rural Alabama. Dr. Vester's 68 years old, and actually, she'd really like to retire, but she's one of the only doctors in town, and she can't find another doctor to take her place, and she's not about to abandon her patients. So she's out there hanging on for as long as she can, hoping that someone is going to come along and fix the physician shortage. They also spoke with a woman in New York City named Olga Torres. Ms. Torres has been looking for a new PCP for 2 years, and she still can't find one who's taking new patients. Here's a headline from the Boston Globe. Primary care access is declining in Massachusetts. Quote, "We've never, ever seen numbers fall like this," it says. "Physicians are leaving private practice and few young doctors replace them," it says. And if this is what the physician shortage is doing right now to places like New York City and Boston, which are two of the cities where there are more doctors than almost anywhere else on the planet, then we all know things are going to be worse elsewhere. So here's a story from a local news station out on the central coast of California, 200 miles from San Francisco or LA. They talked to this gentleman, Mr. Jerry Ross, who has lost his PCP, and when he finally found another, the appointment he was given was nearly a year away. This physician shortage is bad, and it's going to get worse, right? Don't answer yet. Let me move on. Here's a headline from the Idaho Statesman newspaper describing the healthcare shortage in that state. Actually, Idaho has the fewest doctors per capita of any state. But Idaho is also one of 6 states without an MD granting medical school. They outsourced that to the University of Washington. Until 2016, when the Idaho College of Osteopathic Medicine opened, there were no medical schools at all in Idaho. But now, the University of Idaho is opening a graduate school for health professionals, and who knows, maybe in the future they'll get a new medical school and they can finally fix their physician shortage. And maybe you don't care about Idaho or the central coast of California, but I promise you can find a story like this in any state you want. So here's the headline of a magazine article that summarizes the rural doctor shortage broadly. It's impacting patient care and outcomes, it says right there. The article goes on to quote the former president of the American Medical Association, who says that, quote, "These disparities are at the root of why rural Americans suffer disproportionately high rates of diseases like diabetes, stroke, and heart disease," end quote. And here's a quote from the current president of the AMA, Dr. Jesse Ehrenfeld. It's from an article in a magazine entitled The nationwide doctor shortage is forcing patients to search for primary care. And Dr. Ehrenfeld highlights another bad thing that happens when you don't have enough doctors. Quote, patients end up bouncing around, going to urgent care, clogging emergency departments, or just not getting medical care at all, end quote. And this physician shortage, it's not just primary care physicians. There are shortages of specialists too, and those may be even worse. Here's a story from the New York Times. The 6-year-old boy in this picture lives in Oklahoma. He's got asthma, severe enough it's put him in the PICU. But to see a specialist, his family had to drive 14 hours to Denver, Colorado. These are stories that pull at your heartstrings, and they should. So obviously, we need more doctors, right? Now, so far, all these headlines just talk about basic access to the doctor, but what happens when you're there? Well, here's an NPR story on the physician shortage, and it highlights another problem. The quote is from Dr. Candace Chen, who is actually one of my favorite follows on Google Scholar for her health policy work, but she's also a practicing pediatrician who works in Southeast Washington, D.C., which is a very underserved urban community. And as she says, quote, when we don't have enough other physicians, it means that we're scheduled appointments every 15 minutes, end quote. And that is just not very much time to take care of anyone, much less children who bring lots of complex medical and social concerns to each visit. And then there are wait times. Here's a good long read from Philadelphia Magazine. The headline, why is it so hard to get a doctor's appointment in Philadelphia? If Philly is one of the great medical cities in America, why does it take so long to get a doctor's appointment? And it describes long waiting times everywhere. 4 months for a PCP or allergist, 6 months for a dermatologist, a year and a half for a routine GYN exam. And 1 in 6 doctors in the whole country get their training in Philadelphia. Sounds like some other cities need to start pulling their weight and fix this doctor shortage. Well, good thing some other states are stepping up. Here's a headline about how the University of Georgia will be opening a new MD granting medical school. In this article, we get to hear from the founding dean who says, quote, this is a historic day for both the School of Medicine and our state. This milestone gets us one step closer to putting more doctors in Georgia to help alleviate the physician shortage, end quote. And here's another from the other side of Pennsylvania, where Duquesne University just opened up a new osteopathic medical school. It's located less than 2 miles from the medical school at the University of Pittsburgh, but the president cites the AAMC's estimates of the looming physician shortage and explains how the new medical school will promote equitable access to health care in underserved urban and rural areas. But as we all know, merely increasing the number of medical school graduates is not enough because doctors need residency training too. But fortunately, hospitals are also stepping up to do their part to fix the physician shortage. Here's a headline from Riverside Health, which is a small hospital chain in Virginia. 3 years ago, they started a brand new emergency medicine residency program. And here's the headline from this year. Addressing the physician shortage. Inaugural internal medicine residency is an investment in our region's future. And here's one from HCA Healthcare, pointing out how they've dramatically increased the number of residency training positions that their hospitals sponsor. In fact, as you can see from the headline, in 2022, they offered residency positions to 1,867 medical school graduates to help address the national physician shortage. And HCA is not the only one pitching in. Even United Healthcare, the nation's biggest insurer, understands what a dilly of a pickle we're in with an aging patient population and more healthcare workers experiencing burnout. So they made a, quote, whopping $100 million investment to tackle the workforce crisis, end quote. So all of this is very good, right? We have this physician shortage, and it's causing all kinds of problems for us. Access to doctors is poor, wait times are long, visits are short, and we've got inequities in access that are especially problematic in rural areas and underserved communities. So it's very obvious exactly what we need to do, right? Actually, I'm going to let Dr. David Skorton, president of the AAMC, take over from here. It's clear that both sustained and increased investments in training new physicians are critical to mitigating projected shortfalls of doctors needed to meet the healthcare needs of our country. Boom. Mic drop. We may have big problems in our healthcare system, but we can meet them with a big solution. We're going to get more doctors. I mean, I told you the numbers, and I told you about the problems that result from those numbers, so what more do you need to know? But you probably remember, I didn't call this video, Tell Me About the Physician Shortage. I called it, Tell Me Again About the Physician Shortage. So what I'd like to do now is walk back over some of this familiar ground that we just tread over together. Only this time, we're going to look at all these things just a little bit closer. Let's start here with the AAMC's estimates of the physician shortage. And let me just tell you, their estimates are ubiquitous. In fact, the next time that you see one of these news stories, or you read about or hear some politician or policymaker talking about the physician shortage, if they cite a figure, I challenge you to look at where that figure came from. 90% of the time, it's from the AAMC. All the articles that I just showed you, to the extent that any of them did something more substantial than just noting the looming physician shortage, to the extent that any of them did something more than that they actually felt the need to provide some data, the data they provided came from the AAMC. Is there any problem with that? Well, the Association of American Medical College isn't exactly an unbiased analyst. The AAMC functions as a trade organization acting in the interests of medical schools and academic medical centers. When you ask them to solve problems in the American healthcare system, they're going to have a tendency to see it through a certain lens. I mean, what do you think would happen if we commissioned the National Automobile Manufacturers Association to study the problems in our nation's transportation system? What kind of solution do you think they're going to recommend? Look at this guy, stranded at the airport because his flight was delayed. Look at these sad sacks sitting around in the rain at the bus stop. These people need cars. We could fix all the transportation problems with more cars. I mean, would you be surprised to hear that? Of course not. They have a financial conflict of interest. And so does the AAMC. As you've heard before on this channel, the AAMC's top leadership is handsomely compensated. Their president took home nearly $1.4 million in total compensation in 2022, and the amount of compensation that executives receive is ultimately related to the organization's revenues. So how much more revenue would there be if we had a bunch of new dues-paying medical schools? How many more MCATs could you sell? How many more fourth years are going to pay through the nose for ARIS? And I won't even get started with the academic medical centers yet. I'm going to save that for a little bit later. But you know that old saying, when the only tool you have is a hammer, every problem's a nail? The AAMC is like the hammer factory. But having a financial conflict of interest just means you're incentivized to see things a certain way. It doesn't mean that way is wrong. And the AAMC's modeling, it looks authoritative, right? Look at this graphic here showing physician supply and physician demand under a few different assumptions, and you can still see demand outpacing supply in almost every scenario. So is there anything that's substantively wrong with their analyses? I think there's a few things here that you could quibble with because this is a complex system and any change you make is likely to lead to other compensatory changes. But I'm going to highlight just one big assumption for now. I'll come back to some others later. To determine physician demand, the AAMC assumes that tomorrow's doctors are going to practice the exact same way that today's doctors do. So the model takes that we have X number of doctors today and we have Y number of patients, and the patient population is going to grow by a certain amount over time. So if we assume that the ratio of X to Y stays the same, then we can create these models where we can vary other things and see if we're going to have a shortage. But let me ask you a question. This is Dr. Michael DeBakey. He's one of the most renowned surgeons of all time. This picture is from 1969, and of course, Dr. DeBakey was one of the first surgeons to perform coronary artery bypass graft or CABG procedures. By the time this picture was taken, Dr. DeBakey had been doing them for about 5 years. So if we could go back in time to when this picture was taken and ask Dr. DeBakey how many cardiothoracic surgeons we were going to need in 50 years, what do you think he'd tell us? Now remember, coronary artery disease was, back then, just like now, the leading cause of death in the country. So there's a huge population of patients who have plaques in their arteries, and now we finally have a surgical procedure that can lessen suffering and extend life. You just need very, very skilled doctors to deploy it. So how many of those very, very skilled doctors do you think we need to train? A lot, right? Of course, what Dr. DeBakey wouldn't have known was that the rates of adult smoking in the United States were going to drop from 43% in 1965 to 12% in 2022. And he wouldn't have known that by the mid-1980s, we'd have medications like statins that could effectively lower cholesterol. And he couldn't have known that by the late 1970s, cardiologists were going to be doing percutaneous interventions and placing stents that would eliminate the need for CABG for many patients. So the net result is that the per capita rate of patients receiving coronary artery bypass grafting peaked in 1996 and actually has decreased since. Turns out we actually need fewer cardiothoracic surgeons than you might have anticipated 50 years ago. Or here's Dr. Edward E. Mason, who's considered the father of bariatric surgery. Now, if I asked you, even a few years ago, how many bariatric surgeons we needed to train, given that the rates of obesity in the United States were climbing steadily and showed absolutely no sign of stopping, what would you have said? But what you couldn't have known was that we were going to have medicines like Ozempic or Trulicity that would obviate the need for gastric bypass for many patients. Or let me give you one from my world. I spend a lot of time managing hypertension, so I prescribe a lot of ACE inhibitors and angiotensin receptor blockers. Well, here's a paper from the New England Journal of Medicine last year describing an experimental medication that inhibits the production of angiotensinogen. It's a small interfering RNA, and patients receive it as a subcutaneous injection twice a year. So how many pediatric nephrologists like me do you think you're going to need to manage hypertension if all the patient needs is a shot twice a year? Now, maybe this medicine won't work out, but my point here transcends any particular medicine or surgery or anything else. My point is, this stuff is hard to predict. But for now, I want to shift gears because I don't really want to make a physician's per capita based argument to you today. And I'm going to tell you why. As I've shown you, if you turn on your TV or you open a newspaper or website, or I don't know, you simply look around the world in which you actually live, there seems to be widespread agreement that we have a doctor shortage. And the reason there's widespread agreement is not because people agree that the ratio of physicians to patients is less than some abstract threshold and it needs to be slightly more than this threshold. It's because people perceive that a lack of doctors is causing concrete, identifiable problems in their lives. So what I'd like to do is work back over some of those problems that we touched on earlier. So tell me again about Dr. Vester. Remember, she was the family physician who couldn't retire because she couldn't get a physician to replace her in her rural Alabama town. Well, in her brief interview on NBC, Dr. Vester made this comment. There have been doctors that come through here, but they don't stay. Now, what should we make of that? I mean, this sounds like there might be a slightly different problem here than just a pure deficit of physicians. I mean, why would doctors come and then seek opportunities elsewhere? I want you to ponder on that for a moment while I move on to the second part of the NBC story. You remember the second part with Miss Torres, right? She was the patient in New York who lost her primary care physician and couldn't find another. Tell me again about that. Well, the NBC story explains why she lost her primary care physician. They transitioned their practice to a direct primary care concierge model. No more insurance, just straight cash, homie. And the fee that her doctor required was more than Miss Torres could afford. Oh, and oh yeah, that story about Mr. Ross in California, the gentleman who had to wait for a year for his visit with his new PCP. Same thing happened to him. His longtime PCP switched to concierge medicine. So I guess I gotta ask, do you think training more doctors is gonna fix that problem? Put another way, do you think that new doctors are going to behave the same as or differently than our current doctors? If we train more doctors, are they going to go to work with Dr. Vester in rural Alabama, or are we simply going to have a larger group of doctors who come and go? If we train more doctors, are they going to help Ms. Torres and Mr. Ross, or are we simply going to have a larger number of doctors who face the same incentives to step away from the insurance system and become direct primary care physicians? And all these questions beg another question, which is, why do doctors make the practice decisions that they do in the current system? So tell me again about the primary care crisis in Massachusetts. Actually, I feel like I just saw something else in the news about physicians in Massachusetts. What was that? Oh, well, I'm sure it'll come to me. Anywho, I showed you this Boston Globe headline before about how primary care access was declining. Nobody'd ever seen numbers fall like this. Well, why would that be? I mean, Massachusetts has more physicians than almost any other state. In 2024, actually, there were 234 PCPs per 100,000 people in Massachusetts, which was the third highest among all states. To put that in some perspective, states like Arizona, Georgia, Texas, they have about half that. So why is there so much turmoil over primary care in Massachusetts? The reporter knows the answer. Actually, if you click on this video that's embedded in the newspaper story, the host asks her that question. The first thing out of her mouth, quote, "A lot of it is financial," end quote. Oh, wait, I remembered that other story that was just in the news about primary care physicians in Massachusetts. It was this one, describing how 400 of Mass General Brigham's primary care doctors were having a vote on whether to form a union. You know, if you went back in time and showed this headline to doctors 30 or 40 years ago, I think they'd be more shocked by this story than one about ChatGPT. You know, doctors forming a union? You got to remember, until recently, most doctors were self-employed. They would see a picture like this. I mean, who's the man keeping you down? I mean, why are you picketing yourself? Obviously, times have changed. Since 2022, the majority of physicians are employed, and the majority of those are employed by enormous hospitals and health systems in which most individual physicians have very little, if any, leverage, because individually, a primary care physician at a place like Mass General Brigham is easily replaceable. And so, in order to improve their working conditions, these employees have turned to the same tool that other generic, easily replaceable workers like dock workers or coal miners have used, which is collective action. Because individually, these doctors are replaceable, but collectively they're not. So if primary care physicians at one of the premier health systems in the whole country feel that they can't take adequate care of their patients because they're being run like hamsters on a wheel by an enormous financially motivated corporation, and they have to turn to collective action because each one of them is so easily replaceable that they're powerless, do you really think that patient care or physician working conditions are going to improve if we just churn out more doctors? I'll let you ponder that one for a few more minutes, but I want to come back and I want you to tell me again about how doctors' appointments are so short because of the physician shortage. Remember the NPR story that had this quote from Dr. Chen? "When we don't have enough other physicians, it means we're scheduled appointments every 15 minutes. Well, actually, if you listen, she didn't stop there. If we continue on, she said, "When we don't have enough other physicians, it means we're scheduled appointments every 15 minutes to hit the revenue marks and to make sure the clinic can keep their doors open." Please let that hang in the air for just a moment. So unless they pack the schedule and see someone every 15 minutes, the clinic isn't going to bring in enough revenue to even cover their overhead costs. But we can fix this by training more doctors, right? You know, I don't know about you, but I'm starting to think that some of the problems that we chalk up to a physician shortage actually have other causes. And I guess I'm not that convinced that having more doctors is going to fix things. So tell me again about wait times to get into clinics. I mean, we heard before about how patients in Philadelphia were waiting weeks, months, years to see different kinds of doctors. I mean, the physician shortage, am I right? Well, all these news stories are full of anecdotes, so if you'll indulge me, I'd like to share one of my own about wait times. I work as part of a small group of physicians in my specialty, and over the years, at times my group has been fully staffed, and at times someone leaves and we'll be down a doctor for a period of time. Now, as a matter of principle, we try to get patients in to see us, new patients, as quickly as possible. And certainly if there's something urgent going on, we will always get them in. But for routine, non-urgent visits, we have a little bit of a wait, but it's not much when we're fully staffed. I mean, you might have to wait a couple of weeks, but actually a lot of the time you can get an appointment within a few days. Now, when we're not fully staffed, our wait times start to increase. And those times, it might get to be several months to get in to see us. And when that happens, I've repeatedly observed that something interesting occurs. Our cancellations and same-day reschedules go down. And it should be obvious why this occurs. I mean, sometimes you make an appointment, but when it gets to the day of your appointment, something comes up, or you're busier than you thought you'd be, or the weather's bad, or whatever, and it's simply no longer convenient for you to keep the appointment that you made. So if you call the doctor's office and they say, oh, sure, you can reschedule your appointment tomorrow, or the next day, or next week. Oh, well, thank you. That sounds great. Sorry I couldn't make it in today. But if you call the doctor's office and they say, well, our next available appointment is in 3 months, well, by God, you're going to get your child to the doctor's office because you're a good parent and it's too bad that you have to rush out of your meeting. If you make the cost of rescheduling high, fewer people will pay it. And so, unfortunately, in a world in which administrators and office managers understand that all of the profit that you make is in the last couple of patients a day, everything before then just covers your overhead, you want it to be costly to cancel or reschedule the same day. Because if you don't make it costly and people cancel, you probably won't fill those spots. And there goes your margin. So tell me again, AMA President Dr. Jesse Ehrenfeld, how the primary care physician shortage is why patients end up bouncing around or clogging up emergency departments. Let's do a little imaginary role play. Pretend that you're the office manager for a primary care office in a big health system. How many gaps in your employed physician's schedules are you going to leave open for same-day sick visits? Probably not that many. Because if you leave 4 spots and only 1 sick person needs to be seen that day, well, I mean, you might as well have had 3 no-shows. And if that happens too many days in a row, well, now you're going to have to answer to your direct report in the C-suite about why your metrics missed the mark. But I mean, heck, even if you had 4 sick patients who called that day, there's no guarantee that the 4 slots you're saving are going to suit the patients and their schedules. I mean, we have an appointment at 10:20 a.m. No, thank you. Even if you have a spot, the patient may end up in urgent care anyhow. Or if you tell them, well, just come on over, the doctor will work you in. Well, now the sick patient's going to have to wait, and now they're upset. And regular patients who had to wait and sit with the sick patient in the waiting room, now they're upset, and everybody's just having a bad day. I mean, you might as well just send them to the ED and let their Press Ganey scores take the hit. My point is, clinics have strong incentives to keep their schedules full. And those incentives are the same. They do not change, even if you put a few new doctors in town. As a side note, if you're worried, like Dr. Ehrenfeld, about patients bouncing around and going to urgent care, I think you're facing an uphill battle. I mean, have you noticed that amidst all the moaning about the physician shortage, you don't hear people complain about a shortage of urgent care centers? And why would they? The number of urgent care centers has doubled over the past decade. So are we supposed to understand this explosive growth as being a result of having too few physicians? Because if that's what you want me to understand, I'd first like you to explain with some specificity what data about physician supply changed so dramatically between the years 2014 and 2023 that would support such a conclusion. There's something else going on here. So you can say what you want about the quality of care at urgent care centers, but in reality, market research shows that a growing number of patients, especially Gen Z and millennials, they prefer to go to urgent care centers, even for routine care, because of the flexibility and convenience. More and more urgent care centers are positioning themselves to provide primary care services to these younger patients who don't want the hassle of a regular doctor's office. 1/3 of urgent care centers now provide smoking cessation and behavioral health services. 28% of urgent care centers provide chronic disease management for problems like hypertension and diabetes. But I don't want to get too far off track. Actually, I want you to tell me again about this story. Healthcare shortage has plagued Idaho for years. Here's what the U of I is doing about it. And if you read this article online, like I did, when you get to the bottom of the page, the newspaper suggests other articles that you might be interested in. And the first article that they thought I might be interested in was this one. Here's the headline: Idaho needs doctors, but many don't want to come here. What that means for patients. And indeed, this was something that I was interested in, so I read on. And the article describes how Idaho has the lowest number of doctors per capita of any state in the U.S. But, quote, even in areas of the state with a high population density, such as the Boise area, patients often face months-long wait times to see primary care physicians, even though most providers are already concentrated in those places, end quote. And it goes on to describe how a large medical group called Salzer Health, which ran 11 clinics and saw 100,000 patients a year in the Boise area, was going out of business. I guess it might be hard to recruit physicians to work in a state in which primary care reimbursement is so poor that even a busy medical group seeing 100,000 patients a year in the biggest city in the state, and they got a months-long waiting list, is going bankrupt. But hey, what do I know? Maybe we just need more doctors. Let me keep reading on. Next, the article describes how after Idaho passed one of the most restrictive abortion bans in the country, one which requires jail time for physicians who provide abortions, the number of obstetricians in the state dropped by 22%. If this is the problem you're trying to fix, it seems like there could be a simpler solution within your grasp. I don't know. Now, the article highlights some other things as well, and one that caught my eye was a comment about the fact that Idaho funds their public education system very poorly, which might turn off physicians who have children. And honestly, I think that this gets us to a very important point when we're talking about physician shortages. If your goal is to have more doctors work in places where they currently don't choose to work, you ought to begin your problem solving by first trying to understand why physicians avoid those locations right now. Because otherwise, I think you can reasonably expect that you're only going to train a larger number of physicians who will have the same preference for places where they want to work. So why don't doctors want to work in rural areas? This is a complex issue, but I'm going to speak frankly about a couple of things in play. First, here's your periodic reminder that over half of U.S. medical students come from the uppermost socioeconomic strata of American society. The median U.S. MD student is someone who grew up in a big city or its suburbs and they had certain amenities. And when they dream about their future career in medicine, they don't dream about giving up those amenities. They want a Trader Joe's or an international airport or sit-down restaurants that aren't part of a chain or youth lacrosse and field hockey leagues or schools that send graduates to big-name universities. There just aren't a whole lot of medical students who come from truly rural areas. And to be honest, even among that group, many of them aspire to a career in medicine because they want to achieve upward social mobility in a geographic area that has more amenities. We do a very poor job of recruiting medical students who want to practice in a rural area. If you look at the AAMC's matriculating student questionnaire, it's around 5% of the incoming class that say that they want to practice in small town or rural areas. 5%. And actually, if you ask the same students at the end of medical school, which the AAMC does with its graduation questionnaire, that 5% is down to 3 or 4%. And that's before people even do their residency training. And once you do that, you're going to realize that many jobs in rural areas are substantially harder than those in a big city. I mean, in general, you're going to work in a smaller group and you're going to take more call. And even if you're a shift worker, like an EM physician, if you work in a rural area, you will not have the backup and immediate access to specialists that you enjoy in a big medical center. I mean, the cath lab or that surgical specialist, they can't immediately take this patient off your hands. You're on your own, brother. My point is, I think this percentage is going to dwindle even further from that point. So put on your policy hat for just a moment and think about this. We want more doctors who will work in rural areas, right? So is the best policy to simply expand medical school class sizes? I mean, what do you think, Professor?
Well, according to my calculations, with 4 out of the 100 doctors in our class currently interested in rural care, if we merely double our class size, we could see that figure rise to 8.
Is this really what we think? That this is some kind of numbers game? Or could there be more efficient and effective policies that we might want to consider if we were actually trying to get people to take care of rural patients? And if you were willing to consider solutions that might generate an extra unit of desperately needed rural physicians without training 19 units of physicians that we didn't need, well, there's obviously a lot of sensible things that you could consider. But let me point out one thing that you're going to have to, and that's this. You know, the healthcare economy, it's a funny thing. What a physician earns is not determined so much by what they do, but by to whom they do it to. In my state, Virginia, for instance, Medicaid reimburses just 78% of what Medicare does for the same billing codes. And as you can see from this map from the Kaiser Family Foundation, many states do worse than that. On the other hand, private insurance pays, on average, nearly double the Medicare rate. So if you're a gastroenterologist and you do 10 endoscopies on Medicaid patients, you'll collect 40 cents on the dollar from what you might have received if you did 10 endoscopies on patients with commercial insurance. This is one of the fundamental problems that you're up against when you talk about geographic disparities to physician access. You show me an underserved area, and I'm going to show you an area with an unfavorable payer mix. Let me tell you about a little experiment that was done a few years ago. It was published in the New England Journal of Medicine. If you want to read the whole paper, I've got the reference there below. But let me tell you what the researchers did. They randomly selected 273 pediatric specialty clinics in the Chicago area, and they called each of them and tried to get an appointment for their child who was sick. Of course, their child wasn't really sick. They used one of these disease scripts that I'm showing you here to explain why they needed an appointment for a hypothetical child. And as you can see, all these complaints are straightforward, medically justified, bread and butter complaints for that specialty. You got a 7-year-old with new onset type 1 diabetes who needs to see the endocrinologist. You got a 12-year-old with a forearm fracture who needs to see the orthopedist, whatever. And the script here that the callers used was standardized. Every clinic got the same information about the fake patient, except for one thing. Half the time, the caller said that they had private commercial insurance, and half the time, they said they had state Medicaid. Now, what do you think happened? If you had private insurance, well, there wasn't really a physician shortage for you. 96% of those kids got in with a dermatologist, 98% got in with the orthopedic surgeon. As long as you had insurance, 100% of the allergists and otolaryngologists had an open slot that they would happily reserve just for you. But if you had Medicaid, well, now suddenly the physician shortage rears its ugly head. 2/3 of the time, the clinics said they had no availability. 2/3. And even when clinics accepted both private insurance and Medicaid, the wait time was 3 weeks longer for the Medicaid patients. I think after all this wind up, I'm ready to lay out the first of my big 3 takeaway points. But let me just say one more thing first. We have a lot of problems in our healthcare system, and although in this video I've often spoken in a mocking tone, I want to make it clear that my disdain is for the credulous news media and our supposed leaders and big thinkers who fail to exercise even the least bit of critical thinking when they tell us about these problems and then suggest that just training more doctors is the magic solution. But the problems that we've discussed, they are problems for real people, and I have nothing but compassion for them as they try to take care of themselves and their families in a world in which wait times are long and visits are short, and there are significant and shameful demographic and geographic and socioeconomic disparities in physician access. So my first big takeaway, though, is this. Training more doctors is not a magic bullet. So let me issue a challenge. The next time you hear someone talking about a doctor shortage, I want you to think long and hard about whatever problem or data point they're using to demonstrate that we have this physician shortage. And I want you to ask yourself if that problem is really going to change if we simply train more doctors. Most of them won't. The problems that we have are the result of the incentives in our system. If we want those problems to go away, we need different incentives. If we want doctors to practice with Dr. Vester in Alabama, we shouldn't give them such strong incentives to practice in the affluent suburbs. If we want more regular PCPs and fewer concierge PCPs, we need to stop giving doctors incentives that make it so much more appealing for them to do the latter. If we want doctors to work with Dr. Chen in Southeast DC, we can't rely on a business model that requires their schedule being packed to the gills every day with Medicaid patients just to keep the lights on. And before you go and say something goofy in the comments like, that'll cost too much money, brother, we have the money. We live in a nation that spent $4.9 trillion on healthcare in 2023. That figure is up 7% from the year before, by the way. And that $4.9 trillion amounts to 17.9% of our entire gross domestic product. We have the money. We're just spending it in ways that ensure that the very problems that we say we need to fix by training more physicians, we ensure that those problems persist. Yeah. I'd like now to move on to the second of my big 3 takeaway points, and that's this. To the extent they exist, doctor shortages are distributional. Now, don't get me wrong. There could be absolute physician shortages that exist at some scale in some specialties. But on a societal level, the physician shortage is largely distributional. We have shortages right alongside surplus. You don't believe me? Well, let me share some simple modeling from Ezekiel Emanuel that very convincingly demonstrate this point. Dr. Emanuel is, among other things, the chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania, and the figures that I'm about to share came from a 2017 paper that appeared in JAMA. Now, here we'll focus on primary care physicians for this example, and at that time, there were around 450,000 primary care physicians in the United States. But not all of those doctors worked full-time. So here, for the modeling, Dr. Emanuel and his colleagues said, let's be as conservative as possible. Let's just ignore the part-time doctors altogether and pretend that they're taking care of 0 patients. And we'll pretend also that nurse practitioners and physician assistants don't even exist. The only resource that we have to take care of patients are full-time primary care physicians, and at that time in the country, we had around 388,000 of them. Back then, the average primary care physician carried a patient panel of around 2,184 patients. But again, let's be conservative. Maybe that's too large of a patient panel, right? Maybe that figure is inflated because of the physician shortage. So let's slash it to 1,500 and assume that each of our 388,000 PCPs are going to care for only that many patients. How many patients could we take care of using these very conservative estimates? The answer is 583 million, which is really cool because at the time there were only 240 million adults in the United States. Now again, this paper was published in 2017, and by my count, we've had 18 new medical schools become accredited since then. 18. But even back then, we had enough PCPs to take care of nearly 2.5 times more patients than we actually had to take care of. Now I know what you're saying. These figures can't be right. The math isn't mathing. The fact that we have a shortage of PCPs is the bedrock upon which our healthcare policy discourse rests. Well, stay with me here for a minute, because another way of approaching the question of how many doctors we need is, instead of starting with the supply side and thinking about the number of doctors we have and calculating how many patients each of them could see, we could start with the demand side of how many patient visits there currently are and think about how many doctors we would need to satisfy and keep up with that demand. And if we start there, well, we had 507 million primary care appointments per year, and we got to staff all those. So how many doctors are we going to need to do that? And let's not assume that we're talking about grizzled, old-school PCPs who see patients from 7 a.m. to 7 p.m. and then go back to the hospital to round. No, let's assume that we're talking about millennials and Gen Z doctors who came up in a world of duty hour restrictions, and they ain't going to work like that. So we're going to let these doctors work just 4 days a week for just 6 hours each day. Let's call it 9 a.m. to 3 p.m. And that way they have a chance to eat their avocado toast in the morning and get out in the afternoon with enough time to go have some Instagrammable experiences. And during this 6-hour block, we're going to make every patient visit 30 minutes so that the doctor has time to be thorough with the patient. Or who knows, maybe they'll even finish their clinic notes. So each of these PCPs in this model, they're going to see only 12 patients per day. And of course, they need a couple of weeks of vacation each year, so we're going to factor that in too. Now, how many of these doctors do we need to satisfy the current demand for primary care physician visits? The answer is 215,000, which is nice because, if you were paying attention a moment ago, when this paper was written, we already had nearly 2 times that number, and that was the full-time physicians only. Now, what these simple models assume is that physicians are ideally distributed. And of course, that's not a realistic assumption. Patients and their medical needs aren't evenly distributed across time or space, so these numbers aren't going to actually work out in real life. But notice what we did there. If you assume an ideal distribution, we come up with estimates that show we've got twice as many physicians as we need, or the capacity to care for twice as many patients as we currently do. However, if you take the real-life distribution, suddenly everyone's whining about a physician shortage. So, another challenge. The next time you hear someone talking about the physician shortage, ask yourself, is the problem they're describing really a shortage, or is it a distributional problem? Do we need more PCPs? Or do we simply need more PCPs who are willing to take care of underserved patients or work in rural areas? And we've used PCPs as an example, but the same thing is true for specialists. I don't think we need more cash-only psychiatrists in New York or cosmetic dermatologists in Miami. We need to structure incentives for the doctors that we have to practice in the way that we claim we want them to practice and in the places that we want them to practice, instead of structuring those incentives in the way that ensures they'll do the opposite. So why is it then that so many people out there working so hard to raise awareness and advocate and do things to alleviate the physician shortage? I mean, do these people just not believe Zeke Emanuel, or do they have other incentives? And that brings me to my third takeaway, which is that most champions for the doctor shortage are self-serving. So tell me again about the University of Georgia opening that new school of medicine. I mean, it's a project that had broad political support, and people said all the right things about how it's going to improve care for underserved Georgians. And I'm sure there are some politicians who care about that. But I'll tell you something that 100% of politicians care about: the economy. And if you want to know how much the new UGA School of Medicine is going to impact the state economy, well, don't you worry, because they hired a consulting firm to crunch those numbers and put them in a glossy little booklet. And what they came up with is an annual economic impact of $100 million a year right now, which will grow to nearly $400 million a year by 2040. And Georgia is just a convenient example. All new medical schools do this. I guess I should tell you again about Duquesne's new osteopathic medical school. In the school's original press release, they trumpeted how it was going to pump $76 million into the local economy when it opened. For policymakers, more than anything else, that's what healthcare is. It's jobs. It's governmental subsidies. It's a broader tax base. I mean, who wouldn't want a new medical school? And what about the hospitals? Do I need to tell you again about them and help you understand why they're championing the doctor shortage? Because, I mean, if I have to, we can all play dumb and pretend that the reason that hospitals large and small continue to invest in training residents has even the first thing to do with future societal workforce needs, and not the organization's desire for cheap physician labor. Or actually, if you have interest in this topic, I'll ask you to check out my video on what resident physicians are worth. But there is one last news headline that I showed you at the beginning that I do think I need to spend a moment on, and that's the one about United Health Group's whopping $100 million investment to tackle the workforce crisis. Because after all, United Health is an insurer. So isn't it better for them if people don't go to the doctor? I mean, then they don't have to pay for any care, right? I mean, what do they care about this issue? Sadly, if you follow the popular discourse about insurance companies, it will become apparent to you that there are a lot of smart people, even in the year 2025, who simply do not understand the game that insurance companies are really playing. So if you did ask those questions, let me spell it out for you. You know, the Affordable Care Act had a provision called the 80-20 rule that says that insurers have to pay out at least 80% of the money that they take in on premiums by paying for people's health care. So insurance companies can't make money by just denying claims. If they deny 100% of the claims, then at the end of the year, they would have to issue refund checks for 80% of the premium that every customer paid. By law, the maximum profit that an insurance company could possibly make is 20% of what they take in. If they want to make more money, the only way they can really do it is by growing the amount of premiums that they take in each year. Then the size of that 20% that's theirs grows larger. So that's what they do. Every year, premiums rise. This year, the average marketplace plan raised its premiums by 7%. Now, if that number sounds familiar, it's because I just said it a few minutes ago. It's the amount that our total healthcare spend grew in 2023. Do you think that's a coincidence? It most certainly is not. Insurance companies have to file a statement explaining why they're raising premiums, which you can look up if you like, but here's one for sake of example from Anthem of Kentucky. The primary driver of the premium increase is the increase in the cost of healthcare. The increases are associated with increase in the unit costs of services, primarily from hospitals, physicians, and pharmaceutical companies, coupled with increases in the consumption of services or utilization by members. Insurance companies want you to go to the doctor, At least they want you to go a little bit more year after year so that healthcare spend continues to increase and we can all pay them just a little bit more in our health insurance premium. If you can extract at most 20% of every healthcare dollar, you want there to be as many healthcare doctors as possible. And the way you do that is by having as many doctors as possible. I hope by this point it's clear to you that when we're talking about the physician shortage, we're not talking about one problem. We're talking about a lot of different problems, from human beings who have a health issue and don't have a doctor to see, to people whose biggest problem is figuring out how to extract more cash from every healthcare consumer. And to do that, they need doctors to come up with the ICD-10s and CPT codes so the whole money machine can continue to go brrrr. It should go without saying, of course, that some of these problems are more deserving of our policy consideration than others. So just remember, the loudest voices talking about the doctor shortage, they aren't analysts. They're advocates. They're people who have some skin in the game, and they benefit when we collectively decide that, yeah, a doctor shortage exists. And they're using the problems that real patients have to justify policy decisions that may or may not help those people, but they'll sure as hell help them. And honestly, you could say the same thing about me. I mean, I have some skin in the game, right? As a practicing physician, I'm not exactly an impartial observer, am I? I mean, maybe I'm just out here trying to protect the guild. All I can do is ask you to consider what I'm saying logically and rigorously and decide for your own self if you think it's true or if all of our healthcare ails are just going to be washed away with a flood of doctors. And understand this, the flood is coming. I've criticized the AAMC's estimates of the physician shortage, but I want you to take one last look at their projections. The figure that you always hear about from credulous news outlets is the number that you see on top, that we could be 86,000 physicians short by 2036. But notice that lower curve, which actually, probabilistically, is equally as likely as the curve that everybody talks about. I mean, if you accept the AAMC's models as being good, then you look at that bottom curve, it might be that we're only going to be down 13,500 physicians. And I want you to take note also of the slope of those lines, especially the lower curve. I mean, what do you think is going to happen when those steeply dropping curves hit zero and we get to the point where we need no additional doctors? I mean, do you think that those lines are suddenly magically going to go horizontal? Of course not. I mean, medical schools in the modern era don't just shut down. I mean, in the past 100 years, there has been a single MD granting medical school that's simply closed up shop. Hospitals, they're going to keep churning out residents and looking to them for cheap labor. And all the doctors that we trained, each of them may practice for 30 or 40 years. So there's a very long tail on the policy decisions that we've already made. That said, if we're going to appraise this honestly, let's be clear that training more doctors will ultimately decrease physician compensation. I think it's fair to acknowledge that's one of the goals of some of the actors in this space. And even if you are a doctor, I think it's intellectually honest and fair to consider that as being a potential benefit to society. Remember, physician bills make up 20% of our national healthcare spend. But if your policy aim is to reduce overall healthcare expenditures, I think you're barking up the wrong tree. In the first place, even if you cut individual physician compensation in half, if the way you do that is by having twice as many doctors, you're going to spend the same amount. Only now, all the other pieces of the pie are going to grow much bigger because we have twice as many doctors generating the diagnosis and procedure codes that feed the rest of the machine. Moreover, all the free market enthusiasts need to remember that the healthcare economy doesn't have the same rules as the regular market for a variety of reasons. But one of the reasons is this: within some pretty broad limits, doctors have the ability to make work for themselves. And when they do, at best, it creates waste. And at a certain point, that waste becomes unsustainable. I already told you that we spend 17.9% of our GDP on healthcare. You can't have a society that spends 100%. At some point, that growth has to stop. But even if it didn't, physicians making work for themselves is not a harmless thing. We as a society really don't want doctors doing things that don't need doing. When a surgeon starts operating on more marginal cases, there's less chance the patient's going to benefit and more that they're going to suffer unnecessarily. You do enough colonoscopies, someone's going to perf. You prescribe enough antibiotics for URIs, someone's going to get Stevens-Johnson. Real people are going to get hurt. I happen to hold an opinion that's a little different than many policymakers. I don't think healthcare is just economic activity. It impacts people's lives, and it has the potential to make their lives much better or much worse. Honestly, it's shameful that we have patients who want to get care and can't access it. It's almost as shameful as telling this big tale about how we don't have enough doctors to take care of them, when in reality, we've just structured the system in a way that leaves them out. We've all got to decide what kind of world we want to live in. So, if you made it this far, I hope you'll ponder how we can fix some of the real problems in our healthcare system instead of just parroting back this stuff about the physician shortage. You don't have to be their pawn. And folks, that's all I've got. As always, thanks for listening.